Thank you for joining me in our Strategies of Success WebEx series today. This WebEx is entitled PQRS 102, What to Expect in 2014. I'm going to focus on the PQRS reporting system, what it entails, the changes that have been made for 2014, why it's crucial to participate, and how your practice can participate. My name is Carolyn Parker, and I'll be presenting the information on this topic today. Should you have any questions during the presentation, please feel free to submit them as you participate, and I'll answer them at the end of the presentation. Here's our standard disclaimer. The PQRS program, formerly PQRI, the Physician Quality Reporting Initiative, was created in 2006 as a part of the Tax Relief and Healthcare Act. This act required the creation of a voluntary program where eligible providers could receive an incentive for reporting on quality health measures with the goal that clinical data would help drive improvement in healthcare and reduce costs. Currently, the PQRS program is focused on data collection. Success is defined as whether providers satisfactorily report measures. However, it is anticipated that PQRS will transition from a pay-for-reporting system to a pay-for-reporting system in the future. The program applies to physicians as well as to physician assistants and nurse practitioners who report on eligible services provided in Medicare beneficiaries. Credit for quality measures will be assigned to the reporting provider based on his or her individual National Provider Identifier, otherwise known as the NPI. However, payment of the bonus will be based on the Taxpayer Identification Number, or TIN, of the reporting entity. 1 in 5 eligible professionals currently participate in PQRS, with participation increasing 50% each year since 2007. Here's a list of all of the different practitioners that should participate in PQRS. When the Centers for Medicare and Medicaid Services, also known as CMS, rolled out the PQRI initiative in 2007, the likelihood of a return on investment in the face of complexity of the program deterred many physicians from participation. Many who participated did not receive an incentive payment. The program is now renamed as the Physician Quality Reporting System, or PQRS, and there may be reason to take another look at this opportunity to do a quality reporting and, at least for now, receive an incentive payment for doing so. This is the last year that you'll be able to do that under the standard area, but we'll talk more about that later. There are methods of reporting PQRS that have much higher success rate and require less administrative work than the claims-based or individual measures reporting that are so labor-intensive and prone to errors. EHR-based reporting is one option, but if you're not ready for that, registry-based reporting is another. This option requires using a registry to report on one measures group for 30 Medicare patients. In 2009, the success rate for family physicians taking this approach was 97%. The success rate for claims-based reporting of 3 individual measures was 47%. The incentive payment successful PQRS participation in 2011 was 1% of total estimated allowed charges for Medicare Part B physician fee schedule covered professional services furnished during the time in the same pay period. In 2009, when the incentive payment was 2% of the charges, the average amount paid to family physicians was only $1,126. Because the incentive was lower in 2011, the average was around $550, and it's gone down since then to 2013 and 2014, but it will also vary based on the Medicare charges billed per physician. The percent of charges on which the incentive payment is based is set to decrease until it's eliminated. So here's the incentive and how it works. As you can see here for 2014, we're now down to 0.5%. There's not a penalty this year. However, starting next year in 2015, a 1.5% penalty may be applied to the physician's MPFS payments for failure to satisfactorily report PQRS measures. The Affordable Care Act mandates that the MPFS amount paid during the year shall be reduced by 1.5% for 2015 and then 2% for 2016 in each subsequent year for physicians and providers who have not successfully reported in the reporting period established by CMS. The following factors should be considered when selecting measures for reporting. Clinical conditions usually treated, types of care typically provided, for example, preventative, chronic, or acute care, settings to where the care is delivered, quality improvement goals for 2014, other quality programs in use or being considered. I put here a complete list of PQRS measures to click on in this website. For reporting requirements, most PQRS reporting options require an EP or group practice to report 9 or more measures covering at least 3 national quality strategy domains or NQS domains for incentive purposes. So patient safety, person and caregiver-centered experience and outcomes, communication and care coordination, effective clinical care, community population health, and efficiency and cost reduction. So different reporting options. We're going to discuss the various ways your practice can participate in the PQRS system. No registration is not necessary, but to participate in PQRS, if the physician or physician extender chooses to participate, the required PQRS codes will need to be reported on the CMS 1500 physician claim form used for billing professional medical services to Medicare. Individual physician reporting will be tracked by the provider's NPI. So we're going to talk about group and individual reporting mechanisms. So for individual EPs, EHR direct product that is certified, there is a list of those that are out there that have been approved for vendors. The EHR data submission vendor that is CEHRT, through claims or through a qualified PQRS registry. We're going to talk about all of those next. So for individual EPs, you need to choose this option. It's the easiest reporting mechanism to earn both an incentive and avoid the penalty. However, this option is available only through the registry. To avoid the penalty and earn the incentive, practitioners must report at least one measures group and report each measures group for at least 20 patients, most of whom must be Medicare Part B fee-for-service patients, so 11 out of 20. Something for you to watch for. You have to make sure that to avoid the 2016 PQRS payment adjustment, you have to meet the following criteria. You have to satisfactorily report and earn the 2014 PQRS incentive, or you have to report at least 3 measures covering one NQS domain for at least 50% of the EPs or groups Medicare Part B fee-for-service patients. Now for group practices, GPRO was introduced in 2010 as a reporting method for group practices to qualify to earn a PQRS incentive. PQRS defines a group practice as a single tax identification number with 2 or more EPs that have assigned their billing rights to the tax ID. So with the GPRO web interface, choosing that method, you must register that reporting method no later than September 30th of this year. Be in a qualified PQRS registry, EHR direct product that is certified electronic health record technology, or a CMS certified survey vendor. And it has the list of that right under there at how you do a group practice reporting option. Now, if you're a GPRO that wants to report during registry, you'll be required to submit 9 or more individual PQRS measures on at least 50% of the group's applicable Medicare Part B fee-for-service patients. If there's fewer than 9 measures or if less than 3 NQS domains are reported via qualified registry, CMS will apply a measure applicability validation process when determining incentive eligibility. To avoid the penalty and earn the incentive, practitioners must report at least 9 measures covering at least 3 domains. I feel like I'm going to say this over and over again, but they'll keep it simple. For at least 50% of Medicare Part B fee-for-service patients. The reporting periods in a 20-patient sample method via registry. So you have a 12-month period, and that hasn't changed at all from January 1st till the end of the year, December 31st. If you choose a 6-month reporting option, it goes from July 1st to December 31st. It's better if you actually start at the beginning of the year and start reporting on patients from the beginning of the year to be able to capture 80% of the patients, but there's no requirement to participate. It did finalize in its 2012 Medicare physician fee schedule that 2016 program penalties will be based on this year's performance. Therefore, those physicians who elect not to participate or found unsuccessful during the 2014 program year will receive a 2% payment penalty. Eligible professionals do not need to sign up or pre-register. Submission of the appropriate quality data codes, or QDCs, for individual PQRS measures or for measures group in the CMS on Part B claims will indicate the intent of your participation. Eligible professionals who intend to participate via registry or EHR mechanisms should work with your registry or EHR vendor to transmit your 2014 PQRS measure data to CMS in early 2014. You should already be on your way with this. If you're having a hard time with this, you can contact me and I can help you work with your vendors. You have a choice to report, again, over a 12-month or 6-month reporting period. So if there's something you haven't done yet, you want to learn how to do this, it's still not too late. I'd advise you not to wait to June to get started as well, though. So we're going to talk about registry-based reporting, the advantages and disadvantages. With registry-based reporting, the eligible professional group or practice submits the data electronically to the registry, who then captures and stores the measure-related data. The registry is then responsible for submitting the individual measure or measures group information to CMS on behalf of the eligible professionals. Registries provide CMS with calculated reporting performance rates at the end of each reporting period. Registries must pass stringent reporting method criteria annually and be qualified to participate. The 0.5% incentive may not seem like much of a bonus if you have to spend staff time and effort to get proper codes into billing, complete audits to ensure your clinic is meeting the minute criteria, and manually submitting claims to CMS. Although there is a cost associated with using a registry, the savings on staff time and maintaining the productivity alone would be worth it. So the advantages you can see here, the form creation and submissions done for you. There's really no need for auditing to the EMR enforcing measure criteria and selecting eligible patients. Your staff productivity will be maintained. Higher potential for you meeting the reporting criteria and receiving your 0.5% incentive bonus. Using a patient-specific EMR registry gives you the added insight and assistance with choosing the most appropriate measures. And the measures are updated automatically each year as information is provided by CMS. Now, the disadvantages, again, there is a cost involved, but if using some products, it is nominal and definitely provides a return on investment with staff time, paper office supplies, and decreased stress levels are calculated. Secondly, the 80% reporting requirement, but with the EMR in place, 100% data collection really should be your expectation. And then third, data collection enforcement with all eligible patients. We have no choice but to report on each patient. Group practices participating in the 2014 PQRS GPRO reporting via interface will be required to do 17 quality measures, 22 individual measures when the accounting for 2 composite measures. I put on here on the website for assistance how you would do it in this way. For the EHR, you have to report on a minimum of 3 measures for Medicare Part B beneficiaries at an 80% reporting rate to be able to qualify to earn the PQRS incentive payment. So again, here is that for the EHR. Talking more about the EHR product, the CMS and the Office of National Coordinator for Health Information Technology, ONC, they've established standards and other criteria for structured data that EHRs must use in order to qualify for this incentive program. To get incentive payment, you must use an EHR that is certified specifically for the EHR incentive programs, which you can see which EHR systems and modules are certified right here on this website that I provided for you. You need to document all patient care and visits related to the information in your EHR system, ensuring that you identify and capture all eligible cases per the measure denominator for each measure you choose to report, and review all denominator codes that can affect your EHR reporting. If you're submitting your quality measure data directly from your EHR system, you have to register for an IACS account. And I have the information right here, and I'm also going to include the IACS account user guide for submission on the MSO website. CMS wants the providers to move forward in reporting using their EHR, not really through claims or registry. Claims-based and registry-based reporting is limited to providing only little bits of data, whereas using your EHR-based reporting delivers specialized continuity of care documents, painting really a full picture on the individual patient and why medical decisions were made. Under the ACA, CMS must begin applying the value-based modifier to the Medicare fee-for-service reimbursement based upon performance measured under PQRS. The modifier will be a composite of both the cost and quality of care delivered by the provider and will publicly be posted in the Physician Compare website, which is now online. Like the penalties for failure meeting Stage 3 meaningful use deadline, the trigger date for the value-based modifier is next year's 2015 for certain specialists defined by the Secretary of Health and Human Services, and then in 2017 for all providers. The strongest positioning a provider can have in the U.S. transitions to this new reimbursement model and the public transparency of performance is to provide more than just a single data point. For this reason, providers really should be moving to an EHR-based PQRS reporting. A list of the 22 2014 GPRO Web Interface GPRO reporting method measures can be found in the 2014 Group Practice Reporting Option Web Interface Disease Modules, Care Coordination, Patient Safety, and Preventive Care Measures document. That's a very long name. There is a description of each of those 22 measures, and they can be found there as long as the updates made from the measures of 2013 and the release notes can be there as too. For groups selecting the web interface method, CMS will pre-populate the web interface with patient sample population. Successful completion of the 22 web interface measures for the required number of patients will determine PQRS incentive eligibility and performance rates for the measures. To earn a 2014 PQRS incentive payment and avoid the 2016 PQRS payment adjustment, group practices taking part in the PQRS GPRO via the web interface must meet the requirements for satisfactory reporting. Now, going through a certified vendor, this is a brand new reporting mechanism just for this year. Eligible groups with 25 or more eligible professionals wishing to report the CGCA-HPS summary survey models. They're really the equivalent of 3 individual measures and 1 NQS domain. You need to report on at least 6 additional measures covering at least 2 additional NQS domains via the qualified registry, EHR product, or EHR submission vendor. Group practices that don't have an EHR yet, they don't want to go through the registry, they don't want to do it web-based, you can still do them via claims. You're required to identify all eligible cases, report at least 9 measures covering at least cover 3 of the NQS domains, and report each measure for at least 50% of the EP's Medicare Part B fee-for-service patients seen during the reporting period. You do need to watch out for the N365 denial code on your estimated explanation of benefits, which shows the PQRS codes were received by the CMS. So make sure that when you're looking at your EOBs, your billing staff, you should have a person who's auditing, and that when you if you're doing it via claims, you can do this with your practice management system. What we did at our practice when we had to do them with paper before we got an EMR, we actually had an Excel spreadsheet and we interfaced it over from our practice management system, and we would check mark them off, making sure that we had that N365 denial code that they were accepted by CMS. Just note that there will be new remittance advice codes on April 1st of this year to watch out for. If you choose the claim-based reporting, here's the advantages. Claim-based reporting measures are tied to your clinical practice reporting on claims with CPT codes that link to measures. Data submission is the responsibility of the eligible professional or group practice themselves, or your billing company may offer this service for an extra fee. So with the advantages of this, you're in complete control of your own data from completion to submission. Self-auditing process developed to your clinic-specific needs. It is cheaper in the fact that, with software and everything, there's no additional cost. Unless you work with your practice management or if you have a billing company, they may charge you something extra. There's only a 50% reporting requirement. It's okay for a smaller practice or if Medicare is a small portion of your payer mix. The disadvantage is that you have to have someone in the clinic who will own this project. They have to complete audits, know the ins and outs of PQRS, keep record of the percent completed. The auditing process can be tedious and potentially a productivity loss for an employee. You must complete and submit the proper forms in the proper format to the eligible patients. The workload could be significant if a large percent of your patients are Medicare or part of a large clinic, and there's no internal automated check and balance system completed by the billing company. It only will submit whatever you give them. You can review the 2014 PQRS measures list right here on this website that I gave you. You need to determine which measure or measures groups may apply to your practice. Now, please note that the measures groups reporting is not available to group practices. For individual measures details, you need to reference the 2014 PQRS Measure Specification Manual for Claims and Registry under the Download section of the Measures Code page on the CMS website, and it's listed here. Group practices reporting via qualified registry should reference the Claims and Registry Measure Specification Manual and not attempt to report with GPRO narrative specifications. And then you need to choose your applicable measures for submissions that will impact clinical quality within the practice. Measures groups, again, not available to group practices. For measure details, reference the 2014 PQRS Measure Specifications Manual for Claims and Registry under the Download section of the Measures Code page on the CMS website, which is listed here. Measures group specifications are different from those of individual measures that form the measures group. They made it so simple, I know, but that's why I've tried to put the web addresses so that you can click on them, whatever applies to your particular clinic. If you do happen to get confused and don't know which one to pick, please feel free to email me or call me and I can help you with that. You need to choose at least one measures group on which to report. At least a majority of the patients in the measures group, so at least 11 out of 20, have to be Medicare Part B fee-for-service patients. You can review the list of registries that report in the PQRS 2014 measures. It's going to be available in late spring or summer of 2014. If it's the government, it probably will be summer 2014. If it comes out in the spring, that'll be even better, but we'll see. The website's right here. After you select your registry, enter and maintain appropriate legal agreement. For individual EPs, and remember EP is eligible professional, just so the practitioner, ensure that you provide the correct tax identification number or NPI combination to your registry for incentive payment purposes. You need to report your tax identification number and individual NPI to where Medicare Part B charges are billed. On your CMS 1500 paper form, that's field 25, and you need to note if it's a Social Security number or an EIN for your business. use your individual rendering NPI, not the group NPI, in field 24J on the paper claim. For group practices, provide the correct tax identification number to your registry for incentive purposes, report the tax identification number to which Medicare Part B charges are billed, and on the CMS 1500 paper claim form, that again is in field 25. I'm going to give a couple measure examples. This is one of the more popular ones that you can use pretty much in any specialty. It's measure 226. It's NQF 0028, so you'll find those on there. It's a preventative care and screening for tobacco use, screening and cessation intervention. This measure is to be reported for patients 18 years and older who were screened for tobacco use one or more times within 24 months and have received cessation counseling intervention if identified as a tobacco user. So if you're wanting to find one easy to start with to take a look at, this is one that you can pick. Then I also decided to choose an orthopedic specific measure, and this is a measures group. So within this is for the total knee replacement, and there's 4 different ones that fit within there. Now with all of these, and it's kind of small that it's written within here, if you need help picking some of these out or exactly what to do, let me know. I'm going to be doing a follow-up WebEx basically on the denominators, and the sample methods are all pretty clearly laid out there, but you basically have to pick the procedure code. So in this particular instance, you choose CPT codes 27438 or 27442, 27445 or 27446, or 27447. You need to report a numerator option to all measures, which it lists what all of those are within the total knee replacement measures group for each procedure. And then it has all the instructions on what to do with each particular measures group. So if you need help again with any of that, let me know. You can reach me by email, Carolyn, CAROLYNNE, .parker@phvne.com, or you can call me at 402-650-8258. Here is our Prairie Health MSO website for next steps that you can go on to. And you can submit a request for more information by clicking the Submit a Request. If you don't have a login or if you've forgotten it, you can let me know that too. That would be great. If you have any further questions, I can take your questions right now. Thank you so much for your time, and I hope you have a wonderful day.